So you may be wondering why my gastroenterologist is giving you a talk on food allergy. And here's the secret though. So I think you can ask the allergist and they will tell you this, that everything happens in the gut. Both good and bad, it all happens in the gut. And so what I'm going to try and do is over the next hour, just take us through allergy as it pertains to the gut. So my aim is that by the end, you'll have a bit of a skeleton to hang over all the stuff you're going to learn this week and what you probably do in your career pertains to allergy. We'll start off with some basic definitions, think a bit about the pathophysiology of food allergy. We'll sort of try and see how we can classify this. Again, really homing in on that sort of skeleton that would be good to have. As part of the classifications, I want you to make sure you see the inherent problems with them. But then at the end, we'll make it quite clinical. So we'll go through a few cases. There'll be, and then just to sort of illustrate some of the things we're going to talk about today. It's going to be quite interactive. I hope you've got your typing fingers on. We're going to get to do a bit of work on the other side as well. Okay, so let's start. Oops. So what is food allergy? And I think this is where you can get your typing going. Just suggest a few keywords you think should be included in any definition of allergy. It's all very anonymous, I expect. So just let me think what keywords you think should be included if we wanted to define food allergy. Yep, someone said IgE mediated. Okay, good. Adverse reactions, very good. Yep, body reaction for sure. So yeah, IgE versus non-IgE. Very good. Some really helpful things there. Hypersensitivity for sure. Okay, repeatable, that's really important. Hi, Lucy Jackman. So yes, repeatable, so it must be reproducible for sure. An abnormal immune reaction, very, very good. Okay, so those are all very, very critical. So well done, everyone. So I'm going to give you some two definitions. So this one is from the Americans in 2010. So they define, it'll come up on your screen soon, it'll define food allergy as an adverse health effect arising from a specific immune response which is reproducible on exposure to the given food. So these are some of the foods some of the terms that came up with. And then this is another one from IACI. So IACI stands for the European Academy of Allergy and Clinical Immunology. And so, yeah, it comes up with some of those terms you came up with as well. So from obviously the key words that have to be included are an adverse reaction is to food. So very, very basic is to food. And then it's mediated by an immunological mechanism, unknown or unknown, but the immune system must be involved. And then most importantly, it's got to be reproducible. So those are four things. It's to food, it's adverse, it's immune mediated, and it's reproducible. So whatever definition you came up with, if you have those four words, you cannot go wrong. This is probably the first important take-home point. So you probably know this already, but when you talk to your patients in clinic, I think it becomes quite clear that what you mean by allergy is not what your patients mean by allergy. So it's very, very important to be very, very clear what you're really talking about, because humans are saying, but often it isn't. And so in terminology, you probably come across things like food sensitivities or food intolerances. Again, these are quite messy terms because they're not quite as clean as we like them to be. So they can be helpful because pretty much what I think we are trying to say and what our patients are trying to say is that they have food-triggered reactions, adverse reactions to food. And so often it's helpful just to use that general term, an adverse reaction to food. So I use the word GI in the slides there because I'm a gastroenterologist, but actually, it could be anything. So whatever allergic response you think you're talking about, just use the general term, an adverse reaction to food. And then that might be easier. So yeah, be aware you're going to see the terms food sensitivities and food intolerances. But again, what we really mean is probably food adverse GI reactions to food. So this is a helpful chart to find them. The references are there, and if you want them, I can pass them on as well. So when we talk about adverse reactions to food, toxic and non-toxic is a way to start off with. So by toxic, I guess it means, with the intent to harm, things like poisoning, really, Although, if you remember those old Agatha Christie type novels, you always have the nefarious individual who uses allergy knowledge to kill someone. So, it can be toxic. So they're not quite clear cut as we think that they are, but actually is helpful in thinking about adverse GI reactions to food. And then, as we spoke about, immune mediated and non-immune mediated. So the spectrum of food triggered reactions is vast. So you know about things like lactose intolerance. So it's not that there's a problem with the immune system, but they haven't got enough lactose, and to get the reactions of GI discomfort, diarrhea, and those sorts of things. And then you have some individuals that have exaggerated physiological response to naturally containing amines, such as histamine. So some people get tingling when they eat strawberries, and it's just that exaggerated local response, and it's not allergy. It's not allergy necessarily. And then we talk about the immune mediator, which we're going to go into a bit more detail. So the adaptive and the So now here's the next typing question. What causes food allergy? If you're here to answer that question, what do you think is what's the cause of food allergies? Why do we get food allergies? I'll give you some time to type that. Genetic, absolutely. Very good, exactly. So you must be predisposed genetically. Not enough parasites. I like that. Someone thinking a bit lateral there, but for sure, we'll come to that. So yeah, genetic predisposition. There's something about the internal environment, the allergic march. Yeah. So I think once you start to the allergy pathway, you're going to get more allergies. Unknown cause. Yeah. So there's truth to that. There's a lot of things we're still learning about allergies. Environmental factors really important. We need timing of exposure to food. That's something really, really critical. It's probably important to think about. Family history, exactly, linking into allergies and sensitization. I like that. So brilliant. Gut pathology. Okay. Excellent. Excellent. Good words. So this is really helpful. Okay, now let's think about the major players when we're thinking about allergy then. Your gut and your skin. And the reason is to get these two in your minds is that you think of the body, this well-contained organism, and then it's going to react or see non-self by two ways, either via your skin and via your gut as well, via your gut. And then how your body responds is very important. How your body responds to these allergens is quite different in the way your body actually sees them first. And then another minor player, or I say minor, probably a very major player, is your gut microbiome. You've probably heard a lot about the microbiome already in some other talks you've been to. But again, we're beginning to learn that these organisms are not just bystanders or just waiting to kill us, but they are vitally important to how our body works in allergy and in other situations. And I'll try and highlight some of the ways they play a role as the talk goes on. Yeah, so keep in mind the two main players in terms of antigen exposure, your gut and your skin. So the next slide, there's a bit of a delay, but I think it's coming up. Yes, so looking at mechanisms of allergy. So antigen exposure comes via two ways, really, your skin and your gut. And this is where your barrier function is really important. And if you think about it, there's nothing more non-self than food. And so it's a bit of a miracle why we do not get allergies all the time, because food, by its nature, does not belong to us. So given the vast majority of foods that we can eat, it's impressive that we do not get anaphylaxis more than we do. That's because the body has evolved, it's been designed, it's been made to sort of recognize food and prevent this sort of pro-inflammatory response. So I'll give this a very, very brief overview. It's a lot more complicated, but actually at its heart, what this slide is, what I want to use to get this slide is that the default state is tolerance. The idea of tolerance is defined as a non-responsiveness to non-harmful antigens. So focusing on food, a key cell is a dendritic cell. If you want to sound clever, you can say CD positive cells. These are the professional antigen-presenting cells in your body. And what happens is that they live in the lamina propria of your gut. They're sampling antigen that comes through via the antigen. They go to your mesenteric lymph nodes, and then they interact with naive T cells. And then as part of the handshaking that goes on in your mesenteric lymph nodes, you make this population of Tregs, which are the keys for immune tolerance. And what they do is just to dampen the the production of pro-inflammatory cytokines are more of the sort of the other ones that promote immune tolerance. So they are tolerogenic, I think that's how you say the word, and the Tregs are really important to that. So the default state is tolerance, this non-responsive to harmful antibiotics. Food is really important, but the gut microbiome, they're a very interesting group of organisms, because if you think about it, you know about line infections. E. coli plays a very important role in sort of maintaining that barrier integrity. But if it goes by a different way, it makes you really sick. So that's how the body has evolved. That it's sort of a delicate balance, but the gut microbiome is there to sort of promote immune tolerance. There are many ways to do this. Some of the metabolites they make promotes the barrier integrity. Another way they do is actually to break down some of the food antigens, so your body doesn't recognize them as non-self. So that's why the gut microbiome has two ways, and there's a lot more we're learning about the gut microbiome's role in immune tolerance and immune modulation generally. But again, yeah, so those are two main things. But then when these things break down, so if your tolerance to food breaks down, that's when you get food allergy. And then in this case, what generally happens, again, how the antigen is presented, is that you get the T helper response. And as you remember from your immunology, this is the pro-inflammatory state. And then that's when you get your IgA production and lymphocyte class switching, and a pathway that's generally more, that goes down the more adverse route. If your tolerance to the microbiome breaks down, then you get chronic intestinal inflammatory bowel disease. And that's pretty much the key things to take away from this. There's some fascinating work on immunology going on. If you're interested, I'll give you a few more references, but that's the key thing to take away from there. So my next slide is going to come up hopefully soon. This sort of integrates some of what I've been talking about, and then through the sort of super theories as to why allergy happens. And so we'll start with the diverse microbiome. Someone mentioned the environment, the lack of parasites. So this, when you think about the hygiene hypothesis, which I think some of you will be aware of, the idea is that because of the environment is a lot cleaner, less pathogens, there's less variety, and so it just means that you don't get the immune system is actually not as primed to recognize diversity as would otherwise happen. Vitamin D is another thing that has been investigated heavily, as in there's a lot of evidence that this can modulate how the immune system works in terms of allergy. And then finally, there's this it's a bit of a mouthful, but this term that came up, that Gideon Lack, basically Evelina came up with. So it's called the dual allergen exposure hypothesis. So it's a bit of a mouthful, but all that means is that how you encounter that antigen decides what your primary response is going to be. So through barrier dysfunction, if you get an antigen through the skin, then the default for that is allergy or a pro-inflammatory response. And if you encounter that antigen via the gut, then your default response will be tolerance. So this is how really impacted quite a big thing in allergy in the last 4 years or so. You'll be aware of some of the big studies, perhaps those of you interested in allergy, the EAT study, the LEAP study, and the LEAP-ON study. Because previously all allergy recommendations were that if you are allergic, don't eat anything, just stay off those foods. But as a result of the work at the Evelina Allergy Center, showing that actually if you give this infants food early, you can then promote a long state of non-responsiveness or tolerance to these foods. So this is changing how we manage things in the allergy world. But yeah, so this sort of slide, you can look at it in a bit more detail. Is worth going to the reference there, and just sort of integrates the main sort of theories about how allergy comes along. Brilliant. So, okay, a bit of a, oh, I don't want to show that slide. So a bit of a break. Any questions at this point that I should answer before I crack on? No questions. I'm sure Susie will let me know if there's any pressing question I need to answer. So hopefully that makes sense. So it's a very, very brief overview. So now let's go to the next bit of the talk then. So how do you classify food allergy? Okay, you can see my slide there. I'm going to go back there, but that slide, as I'm told, comes from a very famous sandwich joint in Chicago. I've never been. I would like to. It's supposed to be tasty, but you can't deny that it is messy. And I think that's probably the best word to use for for the classification, as in it's not quite as clean as we would like it to be. So when we talk about classification, again, most of these you'll be aware of. So immediate versus delayed. So in terms of the immediate allergies, and that's response. So this is what you see phenotypically. Noise there.
I mean, the big annual meeting is Thursday.
Okay, I'll keep going. There's no automatic way of muting everyone, I don't think, but let's keep going. Okay, so yeah, so immediate versus delayed. The immediate versus delayed forms of allergy and how they respond. So those are two ways, really. Those are sort of ways of of how we use the language and we know what they mean. And so when we think about the immediate allergies, we're thinking about the IgE. So there's a key immunoglobulins that sort of are involved in the allergy response. And then so there's three main ways to think about allergy response. And now your IgE. You can have your mixed pathologies that have IgE components and your non-IgE components, and then you have the ones that are predominantly IgE mediated. And then some classification systems sort of puts a cell-mediated component as well. But then you can even think about it now that even the IgE ones, they don't act on their own. As you know, they are bound to mast cells or basophils, and then when they cross-link, you then get the allergy response. You're going to learn about anaphylaxis later on in the week. So then, strictly speaking, they're not just IgE mediated, but there are cells involved. So again, the idea is that it is helpful, but it is messy because the immune mechanisms are not mutually exclusive. There's a lot of overlap. There are multiple pathways and a bit of redundancy, and they are independent. So just to be aware of that, though, because things are not always as neat as you would like. We'll come to celiac disease later on in the talk. There's some debate about whether this is true allergy or not. I think if we're being very pedantic, then it has to be allergy because it is an immune-mediated response. But I guess it has features of autoimmunity, which makes it a bit less clean. So if you look in papers, you'll find some allergies who call it allergy and others who don't. But either way, you know, it's not straightforward. That's the takeaway. But actually, those broad categories of IgE, mixed IgE, non-IgE, and then non-IgE are helpful because it really helps you when you decide whether your allergy tests will be useful or not. So hold that in thought. So I'm just going to go through some allergic, and you're going to have the slides to this, so I'm not going to go through in too much detail. But these are this is from a paper. It's a really good paper where they try to classify food allergies. And you can see there, so they've used the terms food sensitivity to respond to mean immune mediated and food intolerance for non-immune mediated. I don't think many people do this. So again, just trying to convey that these things are not always as clear cut, but it's quite helpful though, because more broadly, I think it's talking about the two main categories of immune versus non-immune mediated, and then for the food allergy bit, the IgE as the main mechanisms. The next slide is one, again, good paper that's worth your while looking at. And what it does is just to try and integrate all the many allergy responses, not just those limited to the gut. So many of these disorders there, hopefully I'm just seeing, I don't know if this is going to work there. So can you see my spotlight? Has a spotlight come across? Susie can tell me if you've seen a spotlight there.
It doesn't come across on mine, Atta.
No, okay, I'll just use a pointer. Let's see if the pointer works. Does the pointer work?
Yes, I can see the pointer.
A pointer, okay. So I'll just stick with that then. I'm trying to be too techy, never works. So yes, so this slide. Yeah, so I did try to use that, but or highlights. Okay, I'll stick with the pointer and we'll see how that gets on. So yeah, so this sort of tells you that this is helpful because what it means is that any allergic response, whether in the gut or elsewhere, you can always put them into bracket, whether they're IgE, non-IgE, or mixed. And it's helpful to think about these three categories, even though as you're probably, as I'm trying to even though I want to encourage you to be aware that there's always a huge overlap and they're not as neat as we like them to be. So here's the next take-home point. What it helps you to do is to sort of inform your need whether this patient you're seeing requires allergy testing. Mostly, the idea being that there are some times when it may not help you as much, but just by that's why the categorization based on the IgE involvement is helpful. And then, so this is another slide. So all three of them bring something different to the table. So it's up to the talk, go and have a look at them. And what this does is that it's looking mostly at the GI responses. And as allergists tend to look at the IgE-mediated, the immediate ones. So some of the food anaphylaxis, the oral allergy or pollen food syndromes, and the alpha-gal or red meat allergy syndromes. You're probably going to get talks about those later on. But then in this talk, we're going to actually be focusing more on the mixed and non-IgE mediated, because these are the ones that tend to come to gastroenterologists. And then hopefully I'll sort of look at some of the more common things that you're going to see in clinic and the emergency department as well. Okay, so yes, we're going to go on to food allergy in the real. Okay, making good progress. So we're going to go through a case. Okay, so I'll just get through all the stuff there so you can see. So now this, the first case is a 1-month-old infant, normally fit and well. We're told by the family that he's usually breastfed, but then recently they begin to introduce breastfeed. He presents to hospital soon after, about 1 hour after feed, really unwell. The predominant symptom seems to be vomiting and a bit of diarrhea as well. And in fact, his peri-arrest due to the profound hypertension. You treat him appropriately, but at this stage, this is all you hear. What will be your differential diagnoses? Oh, someone's got their FPIES. Absolutely, FPIES is one. So very good. I think it's always good to have at least 2 differential. That's something I always tell my juniors, and I try to practice myself. If you have a differential diagnosis, think of 1. Sepsis, really important, absolutely. And anaphylaxis, very good. So aspiration, sepsis, very, very good. Okay, exactly. So have at least 3. So yes, well done, everyone. That's true. So we're going to think about FPIES versus anaphylaxis, really. And I had this actually based on a real case. So as a registrar, I did see this a couple of years, quite a few years ago now. I did see a child in A&E down who came in with an anaphylaxis to cow's milk. But yeah, this would be your differential diagnosis. Always think about safeguarding. Unfortunately, as pediatricians, that's what we have to do. And then infection and metabolic conditions as well, though, as I'm sure some of you know. Okay, so FPIES, again, this is going to be a very, very brief overview. This is going to be a very, very brief overview. So FPIES stands for food protein-induced enterocolitis syndrome, a non-IgE mediated condition characterized by profuse vomiting. For a lot of these people, I think it's probably more common than we think. Often we think it's sepsis or other things. So it often happens more than once or twice before people begin to realize and tweak that, this may well be FPIES. So the triggers, it depends on the age. For the younger, for infants, it tends to be sort of dairy or soy. And then for the older ones, it can be actual rice or oats. In terms of diagnosis, there are major and minor criteria. So the major thing is that you need to have vomiting. So profuse vomiting 1 to 4 hours after you've had you've been exposed to the trigger food. And there are quite at least 9, and again the references will have this. There are at least 9 other minor categories, and this includes lethargy, diarrhea, repetitive episodes. It happens to other foods, and some of the things you can read on the slide there. So the treatment is allergen avoidance, really, and then if without allergen, they will be fine. And then when they get older, as part of diagnostic, some people use an oral food challenge, part as diagnostic, but also as sort of to see whether they passed on from they've actually recovered from FPIES. This is something done by the allergists. So the allergists will be the ones who treat this condition primarily. So rarely the gastro will get involved with FPIES. Now, in some papers, I think so. One of the big people in allergy uses the term acute versus chronic FPIES. I hold that thought because, to my mind, chronic FPIES is just a bit more messy and it's not quite as clearly defined. So we'll come to that later on into talk. But this is like a 1-page on what FPIES is. So yeah, many of you so well aware of that already. So do think about that when a child presents in this way. So now we're going to go to the next case. Get your typing hands ready. So this is, let's get this up. So a 3-month-old girl on eventful history to date. Now the GP is referred because of a long history of loose stools containing blood. The infant is otherwise well, very, very well and thriving. This should be quite easy for most of you. What will be your differentials? Very well done. Yes, cow's milk for sure. Cow's milk, absolutely right. So, yep, spot on. So you want to use a sort of proper term, allergic colitis. Like I said, always have two differentials in your head. Yeah, proctocolitis, well done. So allergic colitis and infectious colitis will be your differentials. Again, it doesn't feel like infectious, but always think about two things in your mind when you get these sorts of cases, patients. So the proper terminology, which no one uses, is the food protein induced allergic proctocolitis. Now, it's a bit of a mouthful, FPIES. Yeah, it does what it says on the tin. Allergic colitis will do as well. But by and large, you know, blood in stools of an otherwise healthy looking infant. And that's what it is. The triggers are usually cow's milk and soy. There might be other other antigens in the maternal food if the child is breastfeeding. And the treatment for this is allergen avoidance. Again, because they are so well, these are not ones that generally have to come to the gastroenterologist. But again, probably sort of bread and butter, things you see in rapid referral clinics and your general clinics as well. You come across this already, and the treatment will be allergen avoidance, and then they should resolve with that. So just keep in your mind, because remember our definition about trying to diagnose allergy about reproducibility. So keep that in your mind. So yeah, so allergen avoidance, yeah, okay. So coming up to case 3. So this is probably slightly more trickier, or maybe not. So this is a 2-month-old. All infants, uneventful pregnancy, history of difficulty establishing breastfeeds, and just described as a child who's never happy, doesn't sleep well, doesn't take to the food. He's seen by the GP and the ED on multiple occasions, but you know, they just said, okay, it could be they've made a few changes, tried to treat a few things, and the main symptoms are regurgitation and loose stools, but no blood. But then the key thing, because you recognize when he comes to your clinic, is that he's failing to thrive and he looks quite cachectic. So it's gone from the 5th to the 2nd centile. What will be your differential diagnosis in this case? CF, well done. I didn't think about that. That's very, very good. Thinking very laterally, that's really important. Colitis, okay. Yeah. So EOE can happen for sure in this age group. So it can happen at any age, but generally you shouldn't. We'll see. You shouldn't really get the failure to thrive. That's probably the key symptom in this particular case. But we've got to think about it. So you're right. Gastric reflux disease, again, part of the EOE differentials. And I guess the way it might work with failure to thrive is when the child is not getting enough to cause them to grow. So you're absolutely right. But a typical case, I'm not sure what that is. Is this a strange? Okay, I'm going to come back to that one later. So yeah, so I think for this case, again, there's going to be a wide range of diagnoses. I think things like you said, like gastroesophageal reflux disease, you think about those. So a more broader term, we're sort of allergic enteropathy. You know, think about metabolic infection and safeguarding as well as you have to. So according to the sort of non-IgE, this is one of the sort of prototypical non-IgE mediated GI conditions. So FPE, or food protein enteropathy, is very, very similar to chronic FPIES in some ways. But the thing about here is that these children present with variable syndromes. There might be regurgitation, there might be diarrhea, some profuse, some not, and just not being right. But the key thing to make you think there's something going on is failure to thrive. So typically, these sorts of children will then be admitted to hospital because they're not growing. The parents are really struggling, and in hospital they may sort of take a wait and watch them feeding. And then rightly so, if you think the problem is to do with the lack of feeding, then you may sort of take the feeding out, the breastfeeding, you may then give them formula feed and see how much is going in. Then find the child is not feeding, and then you put an NG tube down. When you do that, though, you give them a possibly an extensively hydrolyzed formula, or maybe an amino acid formula, because rightly so, you are thinking about whether this is due to what they're exposed to. And then after a couple of weeks, they don't get better. They still have the symptoms, either they're not gaining weight, the diarrhea continues, or not. And then often they're referred to tertiary centers for investigation. And these ones will generally get an OGD, because rightly so, you're thinking about intestinal failure. intestinal failure. And sometimes in endoscopy, you may find something, other times you may not find anything. But if you do find something, you may see sort of evidence for venous atrophy or changes in the gut, which again are non-specific, but what it tells you is that there's something going, that the inflammation as a result of the antigen has progressed. And so so this child is presenting in failure to thrive. If the enteropathy is bad enough, some of these patients do require a period of immunosuppression just to sort of switch off the inflammatory process. And then generally it would resolve as they get older. What the books tell us is that, or the review articles for sure tell us, is that the FPIES are getting less common as we get older. Less common, they're a lot more common in the 70s. But we know that it does happen. Certainly when I was working in the at Gosh, we see a lot of these families whose children are now recovered. But then as they begin to live through the experiences, you can see them going to quite a dark place in the family life, and some of them are in tears. So although, you know, they get better, I think going through that when you're not quite sure what's going on can exert some significant psychological issues on the family. So someone just asked that, do we see very early celiac? Yeah, we can do for sure, but generally you have to be exposed, as you're aware. You need to be exposed to the to wheat before you get celiac disease, and so at this age you probably won't expect it to happen yet. So this is the F part. That's the food protein enteropathy. And okay, another case. So a 6-week-old infant. Again, we've talked about some of these already. Some of the different. So again, this is one that is very, very common. You will see described as having significant discomfort, crying with feet, drawing his legs up, just quite uncomfortable, back arching, and certainly worse since bottle feeds were introduced. He may have some regurgitation from the history, and he's got a history of cranial cap. So again, nice and easy. What would be your differentials? I'm looking for at least three differentials in this case. Gastroesophageal reflux, absolutely, that's one. Well done. Milk allergy, absolutely. Cow's milk allergy. Colic, well done everyone. Okay, so yeah, too easy for you guys. So yes, cow's milk allergy, reflux disease versus colic. So at this stage, we can actually pause and then have a think about cow's milk allergy. The next two slides have come from the IMAP guidance. Some of you will be aware of that. So it was produced a few years ago, and this is a sort of third or fourth iteration now. And it sort of tells you everything you need to know about cow's milk allergy, as it's sort of designed for primary care physicians, but also to what they call the first contact clinicians who come with children. You can go into in your own time. I'll go into a lot of detail. I will highlight a few things later on. It's a very good guidance, and if you've read the NICE guidance that came out in December 2019 on how you manage cow's milk allergy, it refers to this, and this tells you, and it tells you everything pretty much about how to manage this. I think as a guidance, it's had its controversies. I think some people, some of them have been merited, some of them, many of them not. I think the concerns that, you know, because it seems to push a lot of formula feeds and people want breastfeeding to happen. And so, you know, we are doctors, we always have to argue about something else. But actually going through, I think it's quite a practical guidance. And, you know, they make certainly the most current iteration. It makes a point that actually, you know, as much as possible, we want to sort of push breastfeeding. But often you may not always be able to do that. But then you try and push breastfeeding as much as you can. And then it makes a point, you can see there in the box on the left in red, that the symptoms that they present with are not always caused by cow's milk allergy, but can be caused by many other things. And this part of the sort of, I guess, not conflict, but then when you and your patients may be coming from different sides, because, you know, the patients are very, very certain that it is this. But as clinicians, you know that there might be other reasons why it may not be so, and so you're gently trying to sort of steer them away and you know, into your other differentials, and helping them to sort of cope with the uncertainty that they may not always be as 100% as they would like to be. So that's the next slide. Again, just tells you about how you manage them. So the first slide is recognition. The next slide is how you manage them. Again, I would really encourage you. It's a free download. The references there. I'll encourage you to do those. So the slides are going to catch up soon. So talking about cow's milk allergy, I'll just go through all of that. So it's so you think about it. This are the headlines. My slides will change soon. These are the headlines from the guidance and the ones you read. cow's milk allergy is almost, you could think of it almost like a multi-system disorder. It does involve IgE and non-IgE mechanisms, and every body system can be involved. And so the systems are not unique to cow's milk allergy. So this is why it's important to take a good allergy focus history. So just taking a bit of time for the slides to change over now, so hopefully that'll be the case now. It's not changed yet. Okay, it's getting there now finally. So yeah, so it's it's non-IgE versus non-IgE. Every body system can be involved. It's not unique to, the symptoms are not unique to allergy. This is why you must take a good allergy focus history, something to learn and practice from now. And then you consider, for a lot of these patients, you will consider diagnostic trial with dietary exclusions. And there's nothing wrong with that. It's part of your diagnosis. But then the key thing to remember, again, is that you need to reintroduce to complete the diagnostic loop. If you remember our definition of allergy to start with, it's got to be reproducible. So you need to complete the loop. Now, we've got to be pragmatic. This is going to be very difficult for some families, though. You don't want to get into unnecessary fisticuffs, but at some point, you probably will need to think about that, so you can sort of say with certainty, as certain as we can be, that you're dealing with the dietary allergy. So in terms of dairy replacement, again, this is all in the guidance. We think about soya-based if it's more than 6 months, but by and large, we don't use soya much, although it is something to think about. I think less than 6 months, as you're aware, there's a theoretical risk of pushing up the estrogens in the body, because soya contains something that can be used to make estrogen. Again, this is all theoretical, but by and large, we just don't give it less than 6 months. And then secondly, up to 6% of patients with cow's milk allergy will also have soya allergy. So, you have lots of families that come to you in clinic and say, I changed to soya and nothing got better. And it's like, yeah, well, you're probably the unlucky ones that have a joint response to both of them. So in this case, you're going to think about extensively hydrolyzed formulas, and there are many out there. And then if for the ones that are really severe, then you think about amino acid formulas. If they're more than a year old and at the stage where you're going to introduce sort of normal whole milk into their diet, you can think of replacements such as fortified oat almond, which will then have which is sort of manufactured to look a bit like cow's milk and will have all the calcium and the other things as well. Again, you're already thinking about hopefully you're already thinking about the fact that you will need to make sure your dietitians are involved, because they know a lot more about these things than we do. So there are loads of formulas on the market. You're going to use what your trust uses, and so yeah, speak to your dietitians and find out what's available locally as well. You will know that there's nothing there about partially hydrolyzed formula. They have no role to play in allergy. Some earlier studies seem to think that they could prevent some of these allergies, but again, there's a new paper that came out that showed that it does not. If anything, it makes it worse. So from your point of view, never buy partially hydrolyzed formulas. You may find a few families that have done that, and you can tell them not to do that anymore, because it's not going to help their child. Now, what about testing? Again, you only test if there's evidence for an immediate reaction or other atopic disorder as well. So if you look on the sort of IMAP guidance, you will see then that if you're thinking of reintroducing feed and there is something else there, if it's immediate or you think they have another coincident atopic disorder like eczema or something else, then this is worth testing those children, because it will give you an idea about how much it will persist. And this is where your allergists are really helpful with respect to this. And when you reintroduce your food, don't think about structured food reintroductions or what we call milk ladders. Most children will grow out of it. So it's something worth doing. And some families even do this already. So I'm sure you talk about milk ladders. This is something already in the public discourse. So it won't be something new when you speak to your families. Brilliant. So the next take home point. So never, ever, ever offer blind or blanket allergy testing. It never ends well. You're going to get positive results. You're going to think, oh, what do I do with this now? And then you find yourself in a bit of a muddle. It's just wrong. You're going to offer it to a family, and then you're going to kick off the third wave of coronavirus. I'm serious, just don't do it. Don't offer blind allergy testing. It never ends well, okay? And then your families will probably be asking what's going to happen to their child. And so the next slide is just talking about the persistence, and it's going to come up soon. So peanut allergy tends to persevere by and large, and this is why there's a lot of work from the allergy point of view how you can prevent peanut allergy and treat these children. But then milk and egg, it tends to resolve quite quick by 6 years. Again, note that it's not a complete resolution, about 80% will continue to have a bit of, about 20% will have some symptoms. And the reason for this, if you're interested, is that if you think about your epitope, which is your allergen, the allergen site, so your antibody binding site, the epitope is the binding site on your allergen. There's a lot of evidence now that actually for some of those that are conformational, so the way the protein has been folded, those ones are the ones that tend to, when you denature the protein, doesn't actually cause the reactions. So things like milk and egg tend to be more conformational type epitopes, while peanuts tend to be sequential. So you have all your proteins in a straight line. So these ones tend to persevere. So that's more of an interest kind of thing anyway. But by and large, you can tell your families that if they have milk and egg, it will get better as the child gets older. But as you know, always like a good doctor, don't be certain, don't say, oh, definitely, because when you say definitely, that will be the one patient when it doesn't get better, and they're going to come to your clinic, so accusing you of lying to them. So always try and hedge your bets. Just say it's more likely to find out those words, be encouraging, but never say never or definitely medicine, because as you're probably learning, there's no such thing. As there are very few things you can be definite about.
Just coming up
Susie?
to 14 minutes left, Atta.
Oh, perfect. Okay, good time. Thank you, Susie. Okay, so we're coming to the end now, though. So we're going to change tack really slightly. So this is an older girl, 10-year-old. Again, based on a real case, she and her parents suspect that she's reacting to wheat. These are her symptoms: the rash, nausea, abdominal discomfort, within days of taking the, and then lasts a few days. But then when she excludes wheat, it resolves. So what will be your differential diagnosis? Again, I'm looking for 3, maybe 4, but then let's see what you can come up with. Celiac, well done, for sure, that's one. Celiac, absolutely. Think about celiac. Anything else? Okay, wheat intolerance, very good. We're going to think a bit about wheat intolerance. Anyone want to dig down a bit more into diagnosis? Okay, you've picked the most important one anyway, though. So celiac. So I've used the term there. So celiac disease, you know, I'll give you a very brief overview of that. But then yes, we have this interesting, which you may have heard of before, what we call the non-celiac wheat sensitivities. It used to be called the non-celiac gluten sensitivities. Again, a lot of controversy about what that actually means. As you know, there are a lot of people who have, you know, wheat exclusions become very faddy in our times, though. So, and then there's a debate as to what's driving that. So just keep that in your mind. So those are 2 main things. So for my patients, what I used to tell them was, you know, if they come with any wheat reactions, either going to be celiac disease, a non-celiac wheat sensitivity, or, you know, or delayed food allergy to wheat. The latter 2 is really difficult to differentiate from them, because, you know, from the outside they respond exactly the same, but that just tells you that the immune response, the immune mechanisms may be different, and it's one of the things that we don't know that much about yet, or we're still learning. So we're just going to think a bit about wheat syndrome. So it's a helpful terminology that I've come across. Actually, to be fair, it's only used by one guy who's done a lot of the work on the atypical allergies and the ATIs, but it seems to be quite a good way of encompassing the various adverse reactions you can get to wheat. So wheat is the structure of wheat. For you geeks and sort of would-be pub quizzes around there, wheat is made up of 85% of starch, your carbohydrates, and then the other 15% is made of the storage proteins that helps the wheat to grow and then do all the other things to make wheat wheat. And then you have gluten, made up of gliadin and glutenin. Gluten is what makes wheat starchy and doughy. That's why gluten-free never works out well, because it doesn't have the stuff that actually makes bread and baking good. So gluten is made of gliadin and glutenin. Gliadin is the stuff that actually causes the celiac disease, or is the implicating antigen in celiac disease. And then we have this other protein called amylase trypsin inhibitors, and I'm going to come to that in a bit. So celiac disease, brief review, is a cell-mediated immune response to gliadin. There's some incredible papers that have come out, and I can send those to you. So in the interest of time, I won't spend too long on those. But by and large, what happens then is that in terms of your testing, yeah, you're aware of this. You will send up your TTGs and your anti-EMAs. Your endometrial antibodies are just TTG, which is tissue bound. That's the only difference. And they're both much of a muchness. And then you have your HLA, which is sort of your celiac gene. So they, as you know, this is sort of the key restriction genes that sort of helps you configure your IgGs, as you may remember. And so a while ago, we used to sort of, by and large, historically, we've always done endoscopy to confirm celiac disease. And now we're at the stage now where there's a big push, certainly internationally and from the European Society for Gastroenterology, that we go for a non-biopsy testing for celiac disease. So if you have a patient who comes to you with symptoms and the TCG is high enough, typically more than 10 times the upper limit of normal, you can do a second test, the EMA, and if that's also positive, then that's your diagnosis, really. The previous iteration of the guidance used to say send HLA, but again, some studies showed that HLA were expensive and didn't make any bit of difference to whether the person had celiac or not. So there's probably a limit. There's probably some situations where the HLA is useful. So for instance, if you're looking after a Down's child or someone with type 1 diabetes, those are associated conditions, who usually you will have to screen for celiac every year. If you send the HLA and it's negative to DQ2, DQ8, then you don't need to do endless celiac testing because they're not going to get celiac disease. So yes, if you do your anti-TTGs and your anti-EMAs and it's high enough, that's your diagnosis. And for some patients where it's a bit messier, we'll then do the endoscopy. And the treatment is lifelong gluten exclusion. Now, the non-celiac wheat sensitivities are a bit interesting. And so the two main syndromes in these are the atypical wheat allergies and the ATI sensitivities. So I'm just going to go to the next slide because it is helpful. This was a study that came out in gastroenterology in 2019. The previous one came out in 2014, and it's going to come up quite, okay, you can see them there. This is a graphical abstract. So what we can do now is that you can do this special endoscopy where you can do an endoscopy, camera through the mouth, and then you can actually visualize at a microscopic level the lining of the mucosa. So sort of an endo is called a sort of yes, it's sort of like a laser endoscopy. So it's called a confocal laser endomicroscopy. And so what it can do is visualize in real time what happens at the layer at your mucosal layer when you are challenged with food antigens. So what this group did was that they took a few adults, typically called IBS type patients, and then they tested them to common food antigens. So in the adult case, they used wheat, egg, wheat, soy, and yeast, and dairy, I think it was as well. And so they had symptoms, and then what they did there was to sort of they'd already given them a fluorescent dye, so pretty much go into your blood vessels. And what they could see is that when they challenged these people, they could see in real life, when they challenged them with the protective antigen, they could see almost immediately, within about 5 minutes, a localized reaction where there was edema. You could see this sort of, those tight junctions just pull apart. So there was something happening there, and then what they'd given via the vein actually came into the lumen of the gut. So there was clearly a localized reaction there. Now, this patient did not respond and report symptoms until days later, so up to 24 to 72 hours later, which is like a delayed response. So it's quite interesting because what you see there is this sort of, it's a delayed response, but actually at the level of the mucosa, it was quite an immediate response, if anything. And then, so this is what they've described. We still do not know exactly why this happens. If they measure eosinophils, they are up, and some other genes as well, though that's at the bottom there. So you can differentiate between the CLE positive, the ones that reacted, and the CLE negative. And the ones that react, if you take away the offending antigen, then they get better and they are symptom-free. This was for about 60–70% of IBS type patients. I'm quite convinced that this is how we're going to be in real time, hopefully selecting those patients with non-IgE, what we usually call delayed or non-IgE mediated food allergies. That can almost give you a way of finding out what exactly might be the trigger. It's not widely available yet, but I have no doubt that it will be eventually. So that's quite interesting because in terms of, this is actually for the first time, I think, trying to show that when we talk about the non-celiac wheat sensitivities or delayed food allergies, there's actually a mechanism there that we'll not be aware of. Now, the other protein, the ATIs, now the amylase trypsin inhibitors, they are very, very funny. So I think when this group started out, because the old name is non-celiac gluten sensitive, so they looked into gluten a lot of the time, and they couldn't actually find they couldn't actually find that the studies were really quite random about whether gluten was implicated or not. And then they pivoted to this ATI, this amylase trypsin inhibitors. And then what they found was that this binds really well to toll-like receptors, so toll-like receptor 4. So your TLR4 is one of the innate receptors. What it does is that, again, one of these constitutional there, you don't have to learn about this, it's part of the innate system. And when ATI binds to the dendritic and macrophage antigen presenting cells, when they go to the MLE, then actually starts a pro-inflammatory response. And often this is actually quite distal to the gut itself. So this is one paper that came out in JACI, that's a Journal of Clinical Allergy and Clinical Immunology, showing that if you use humanized mice models and you gave them you prime, so when they say they're humanized, they've been primed so they act as a human being that has an allergic disorder. So they have so the mice model with the right priming, they have inflammation in the intestines and also in the respiratory system. If you give them an ATI containing diet, you can see that the inflammation is actually worse than baseline. And if you take it away, then it gets better. It's not the cause of the inflammation, but it's acting like an adjuvant. That's the term the allergists use to say something that actually potentiates or worsens inflammation. So this has been shown in mice. There's a study that came out later that for some families that have familial Mediterranean fevers, if you give them ATI diet, it gets better. And again, looking to the previous slide I showed you, it can, again, a multi-system sort of thing. So in adipose tissue, in the liver, in the hepatocytes, there's a lot of work coming about. This is actually a very, very important protein in worsening inflammation in these distal sites. So the takeaway point is that for some of those families who say, well, I took away wheat and I got better, it may not all be nonsense. There's actually something there, though. Although for now, it's very, very difficult to actually find out those groups of patients. And I think we're going to get there. So we're still really, really early, really early into how these proteins do work. So it's fascinating. So this can be a pitch for gastroenterology or gastroallergy. Go for it, though.
There was just a question on the chat about HLA.
Yes. Oh, yes. So let me have a look there. So yeah, HLA. So that has been the old way. So if the HLA is let's go through HLA questions. Let's say, okay, so if the HLA is positive and they start avoiding gluten. So again, it's one of those tricky things because strictly speaking, 50% of the population will have HLAs to celiac, but only a fraction develops celiac disease. So what we should do is to get them to, what we have to do is tell them to put gluten or wheat back into their diets, and you explain that actually there's no chance. That is not definitive that they will get celiac disease. In fact, there are a couple of papers that are really interesting. So there was one something that we gastroenterologists see a lot of is some patients that have positive TTGs, and so we scope them and we don't find anything. Now a group actually followed them up for up to 12 years, and what they found was that about 50% will actually get better. So the TTGs will go on their own and they will never develop clinically relevant celiac disease. So which is interesting. So at the moment, because you're TTG positive, doesn't actually mean you're going to get celiac disease. And so even the HLA is much further removed. So it's definitely not a diagnosis. Because you're HLA positive does not mean you have celiac disease in any way whatsoever. So someone says that it's a must for celiac disease. The recent guidance and the evidence again says that it isn't at all. So it can be helpful for a very small subgroup of patients, like we talked about, those where you think screening, or the ones that are really, really messy. There are going to be one or two that I think, okay, it doesn't quite fit. Although, like I said, there are multiple ways that you can get different responses to wheat. But HLA doesn't really help you that much anymore. And so the most recent guidance from SPGAN just says, don't do it. It's expensive. It doesn't really add anything. And again, this has been verified by some 2 big studies in gastroenterology last year, which I think is the push why we're moving away from HLA diagnosis. Okay, so I think we're coming to the end. Oh, Dr. Go, my dear friend, Dr. Go, hello. She's asked a question about whether it was immune mediated. So they're finding some cells at the moment. They did some measurements as to the typical things like the enzyme counts, but it's not. So there's a putative immune mechanism which they haven't proven yet. They know that the eosinophils are high, and then there are the cells there, the occludins, which are part of the innate sort of responses, which are high as well. So that's all they've said. So it's really, really early on. They haven't said it's immune. They've not confirmed in a way that we would like them to as immune mediated. Okay, so then we'll just go quickly. So I'm not going to go through that. The next case was going to be EOE. This is something you come across again. So it's a typical boy who comes in with allergic rhinitis and eczema. maybe has food getting stuck and he needs to push it down. The last slide there just goes into a bit of what EOE is, mediated. So you need to have two things for EOE. You've got to have a history of your dysfunction and also your counts, which are up to 15. The way it presents from young and older children is different, and OGD is mandated for diagnosis. And then in terms of your treatment options, you can go with high dose PPI, dietary exclusions, which are targeted or empirical. Again, because although targeted means you do a skin prick test or some other specific IgE testing before you do it doesn't work that well. So we tend to go for empirical, which we start with 2 and then we build up, and then we go for elemental for the really sick ones. And topical steroids do work. So something that we've used is the idea that we think of, what we tell our families is that you can think of EOE as a kind of eczema of the skin. So typically, if you want to treat it, you use topical cream. That's what the topical steroids are meant to do. Excellent safety profile. And all three of them, after you have a conversation with the families, you're going to pick one. Not many head-to-head trials yet, though, so to whether one, but then I guess it's good. That means you can discuss with your families. Thank you so much for listening. I do speed up a bit when I get to the end, but there's some helpful tips there. I've mentioned them before. Do practice taking a good allergy focus history. I think excellent resources that Susie and Ayn will point you to. They are useful in your immediate IgE dominated, but do not offer them indiscriminately. Always keep an open mind. That's one thing I think I'm learning, that when your patients come with symptoms, keep an open mind. And you may need to do dietary exclusions. So do one, not for too long, but make sure you get it back in again to close that diagnostic loop. And then, engage your dietitians, your allergy spins and your gastro spins, since an MDT approach is very essential. I think that's the end. So I can probably take half a question, half a question if there's time. Anything I haven't covered? Yeah.
We have a question on the chat. Is there a link to non-IgE mediated allergies such as FPIES and other atopic allergic diseases?
Yes, so I think from what I recall, again, because again most of the FPIES are managed by allergists, but I think a small proportion of them will go on to develop IgE, will go on to develop IgE food allergies as well. As to other things like eczema, asthma, I'm not too sure about the in them, but I think for sure with sort of food IgE mediated allergies, a small proportion with FPIES will go on to develop those as well.
Thank you. That was absolutely great talk. I don't think there's any more questions at the moment. I've put the link, I'll just do it again, to the please give feedback. It's really great to know how we're doing and to thank our speakers.
Good for me as well, so please. And thank you so much, Susie and Ayn. Thank you so much for helping. Thank you all old friends that ask questions. Good to see you all. I'm sure we'll catch up when things settle down.
And the learning pack has got lots more information about cow's milk protein allergy. It's got the links to the IMAP guidelines, which Hannah sort of discussed, and sort of some information about alternate milks and other things. So it definitely builds on the talk from today. So please take a look.
I think my slides will be there. I try and get them across PDF so you guys can have all the references are there and stuff that I couldn't cover in detail. I'll send them to Ayn and Susie to pass on to you guys. So, yeah. And on time. Thank you very much, everyone.
Amazing. Thank you so much, Atta.
It was a pleasure. Thank you.